This week, just updating for the Baptist system, we've now performed a little over 900,000 tests, 901,163, and system-wide we've tested 497,557 people for an overall positivity rate of 17.4%. And if we look at the current hospitalization rate, thankfully, it is coming down very nicely still, although sort of plateauing in the 40s to 50s for some days now. If we look at Baptist Memphis, there are 21 people in acute care non-ICU setting beds with COVID-19, and there are 21 people in the ICU as well, for a total of 42, well down obviously from the peaks that we've seen in recent weeks. 17 of those 21 people in the ICU are still on ventilators. That is sort of continues to go along with the problem of some people stay in the ICU for a very long time. And so we've seen seemingly an even higher percentage of those folks in the ICU being on ventilators, and they're in the ICU for that reason. We have 67 ventilators currently in-house at Baptist Memphis, and there are 56 of them in use. If we look at the total number of vaccinated people, 5 out of those 42 were fully vaccinated who are currently in the hospital. And with only one new admission in the last 24 hours, that person was indeed fully vaccinated. If we look at Baptist DeSoto, there are 31 people in acute care non-ICU settings with COVID-19 and 10 people in the ICU for a total of 41, a similar number in both institutions, and 5 out of the 10 patients in the ICU at Baptist DeSoto are on the ventilators. They have 53 of ventilators available and only 8 right now in use. There are only 3 of those people in the hospital who have been fully vaccinated, and of the 3 admissions in the last 24 hours, none of those had been vaccinated. So those are the latest numbers. Be happy to answer any questions if anyone has any.
Hi, Dr. Threlkeld, we do have one question about a report that people who aren't vaccinated can expect to get COVID every 16 months. Can you talk about that, please?
Yeah, it's really interesting. There's it's sort of a model, and it came from the Yale School of Public Health group, and they did some modeling that came out in the journal Nature and some of their online publications. And it's very interesting. It's a very interesting piece of science. It has a lot more reviewing to be done. But if you look at their models, and what they did was they took a combination of the original SARS-CoV, that is SARS itself from years ago, MERS, the one that was kind of between these two, and SARS-CoV-2, and combined the genetic information among those and 3 of the endemic common cold milder coronaviruses. There are 4. They included 3 of those in that evaluation. And they used those sequences and sort of combined them together to predict how long it would take people to clinically relapse from SARS-CoV-2. We know that there's a fairly rapid relapse rate in some of the endemic coronaviruses. You can get the disease and you can get it again in just a few years, sometimes as little as 2 years. Turns out that the antibody decay and the predicted relapse clinically for SARS-CoV-2 was probably even faster than what we saw, at least predicted, with the common cold coronaviruses. So when they looked at it, the conclusion was very clearly that everyone should be vaccinated on top of their natural infection. So they figured by this model that after about 4 months, the antibody levels would decline enough, neutralizing antibodies, where there'd be about a 5% clinical chance of relapse. And if you extrapolated that out to 17 months by their calculation, that it would be about a 50% chance of relapse. So those who would predict that we would need a vaccine every year or two certainly would say that is a point in that direction. But we have to realize that that's a model. It's not clinical data. We haven't had the time to generate those sort of clinical data. But the clinical data that we do see absolutely backs that up so far. If you look at the studies that we've talked about before, certainly those who have natural infection had a 2 to 3 fold improvement in their likelihood of getting the infection again by getting another vaccine, or getting the vaccine, I should say, on top of that clinical infection. So the idea that vaccine prepared immune systems is significantly better than simply natural infection-induced immunity really is borne out by this. And that's the message that the people that that authored this paper really said. They said that it's clear that this model goes along with what we've seen clinically. And it sort of strikes a chord with me, because one of the biggest continued problems that I face in talking to people about this is this idea that natural immunity is better than vaccine-induced immunity. And I would argue that both of them would constitute natural immunity. The immune system is one of the most amazing things in the known universe, as far as I'm concerned. I mean, I trained in academics in immunology related to viral infections, so I'm a big fan of natural immunity. But I think we have to be careful. We can't forget that the main way that vaccine immunity is unnatural is that many of us don't have to die to generate protection for all of us. That's how it's unnatural. The process is essentially the same in terms of the immune system's response, whether it gets irritated by the natural infection or the vaccine. It's just the vaccine carries a very, very much smaller amount of the pieces of the virus that we want to react against. And with that, a much lower chance of any kind of problems along the way. And again, the natural kind of stuff is, I think, portrayed improperly in this circumstance. Smallpox, after all, was all natural, very an amazing particle, efficient in its own way, but in its own way, it naturally killed millions of people through centuries. So, I think that it was much safer to encounter smallpox with a prepared immune system via vaccination. My grandfather was a physician, and he was a big fan of natural immunity, but he was a bigger fan of prepared, vaccinated immune systems because he lost a sister in childhood to diphtheria, something that no one has to face anymore because of vaccinations. We just don't see that in the United States. So I think we have to be careful to let people over-romanticize natural immunity because as if it's some sacred item that should be left alone and not helped out along the way. People will unnecessarily die if we take that approach. So I think this model, despite being only a model with all the potential limitations of that, does point out that we have better protection if you get the vaccine on top of what we see as natural immunity, because that immunity to natural infection would seem to be fading, at least by the models, and everything that we've seen significantly has borne that out. That's not to mention the fact that some people, of course, can't get even that degree of immunity from natural infection or from the vaccine for that matter. We saw the death this week of General Powell, a person who had been fully vaccinated, and some would even sort of try to use that as saying, see, you can still die if you're vaccinated. And that, though true, has to be brought out the fact that he had multiple myeloma, a disease that particularly impairs B cell function and thus our ability to have a response to vaccines. So when you look at the fact that so many more people are dying right now who are unvaccinated than vaccinated, and even those people who are fully vaccinated who are dying or getting very ill, nearly half of those are people who have immune system problems or underlying problems that would prevent them from maximally responding to that vaccine. So the message, I think, couldn't be clearer. I'm disappointed sometimes to talk to even a few physicians who would say, I'm protected by natural infection, I don't need the vaccine. And I would argue that, number one, you can be 2 to 3 times more protected by having that vaccine, and particularly in protecting people around you. And again, back to the General Powell analogy, there were a string of people that led up to his infection. Maybe a relative, then a friend after that, another relative, another friend, a string of many people before him who got infected that led up to the chain of his infection. And if a couple of those people along the way had been fully protected with a vaccine, that chain would have been broken and he never would have gotten that particular infection. Maybe later, but not that one. And so I think it's very important for us to look at other people and to protect those other people in our lives who may not be able to get this protection from the vaccine. We've seen too many examples of it and too many people die because we've neglected that point.
Hey, Dr. Threlkeld. I had a quick question. I was peeking at this new study that shows COVID-19 is much more likely to kill men than women. in Shelby County, it looks like there's only, I think, 4 percentage points difference between male and female fatalities. And so I wondered if you could comment a little bit further on that study and whether we see these fatalities follow those study trends in Shelby County.
Yeah, I confess that over time, looking at people on the ground, I have not noticed in taking care of people that that's been the case, but that would be the sort of thing that absolutely would have slipped past me as we went about the day-to-day business. Certainly the numbers were relatively impressive on a number of counts in that study. It showed, and it's a pretty good study when you look at the data, about 1.6 times greater likelihood of death in men. That pushes up to twofold about in the middle age group in men compared to women. It at least attempted to correct for underlying conditions. So the fact that women live longer than men in the first place, which we know their life expectancy is greater, you might say, well, that middle-aged men may have accumulated more things that would have contributed to that lower life expectancy. They at least attempted to factor that out as a bias and said that with correction, that shouldn't make a large impact on those numbers. Our Baptist data, we checked earlier today with Dr. Jake Lancaster, who is our all things statistics physician in our system. And the chart that he showed us showed certainly the case that men were dying at a higher rate than women, but it would be impossible to really make a statistical analysis at this point from those raw data, particularly at much smaller numbers than we're looking at when you look at the data from what the CDC looked at. And so, I think that our numbers seem to back that up. But one thing that's important that study also showed is the racial differences in deaths. We found that people who are Black and Hispanics had something like a 6-fold increased death rate compared to Caucasian patients. So that's something that we have to deal with. And if we look at it, you couple that with the fact that people of color have a 6% lower vaccination rate than whites in this country, you're really looking at an opportunity to improve mortality. I mean, we need to point that out to people. That needs to be a message that people of color, particularly men, are at a significantly increased risk when you look at it. The Shelby County data may not bear that out as much, but as you know, the smaller group of people that you look at, the less likely you are to see the full picture. There are obviously other things that could be taken into account. Plus, I think the Shelby County data are raw data. They are not corrected for underlying problems, and it's hard to say whether that, how that correlates if you really subjected them to the statistical analysis. But I think it was interesting, a bit surprisingly large compared to what I had really just thought looking at patients along the way. But I think the important part is to look at people who have higher case rates and higher death rates. Presumably, if this bears out, would be men of color would be a group that we really need to focus on to get vaccinated. That would be a group that we could save the most lives per per unit output of money and effort to put into the public health, I think, issue of this.
Great. And just a quick follow-up, if I could, when it comes to race and COVID fatalities, I hear what you're saying, that study shows there's a 6-fold increase among Black and Latino people. But I'm kind of looking at Shelby County data, and 61% of COVID-19 fatalities have occurred among Black residents in Shelby County. How does our majority minority status sort of fold into, or how does it go against those study findings? Because to me, just the layperson, when I look at this, I tend to think like, well, these fatalities are in line with our demographic makeup.
So you're saying that those fatalities make up what you would expect just as a statistical slice, right, of the population. Yeah, and that could be true in any given community. I think it's, and I really can't answer the question, honestly, because I don't think the numbers in Shelby County have been kind of subjected to the same analysis. And it's early. I mean, these data have just been published and need to be looked at more carefully. And that is true, obviously. But we really haven't found anything else to explain this yet. And that's really the sort of concerning part. When you look at these, it doesn't seem to be as simply the fact that there are different racial profiles in different disease states. For example, we know that in African Americans, there's a higher risk of hypertension. We know that that leads to renal function more commonly than Caucasians, but that doesn't seem to be, at least preliminarily, how that shakes out in the data that they looked at in the larger study. But the problem is, it would be one thing if we could account for those fatalities and worsening disease because of that, but these things seem to attempt to correct that. So I don't think we have the answer to that, but it's something that we obviously need to continue to look at, and something that is being looked at, this being an example of how they're looking at it. But we need to get to the bottom of why that's the case. You've seen any number of thoughts about that. Some of the better data came out of California. Around the UCSF campus, they did studies and they found that, the Latino deaths were higher, the case rate was higher, and that really came down to two issues in that study. Folks in those minorities locally had much higher rate of essential workforce duty, and so they were probably exposed more, and then they were also typically housed in much larger family units, and so there was a larger spread with the family. That would be an example of things that have to be looked at along the way. I mean, how that's translated to different communities, I think, is very difficult to say. So I don't have the answer, and I think it's something that we have to be very careful to look at.
Thank you.
Mm-hmm. Any other questions? There's one question that I have been remiss in answering from the MLG&W folks, and the question was, does the vaccine slow your body's natural RNA pace to facilitate proper immune responses? If so, can this be present in physical symptoms like fatigue or slower mental acuity post-vaccine? And can you explain the differences between mRNA vaccines and viral vector vaccines? I think the most important thing about that is that vaccines, both the viral vector vaccines and the mRNA vaccines, they're far apart in some ways. The RNA vaccine is a much newer technology, but their end product is the same. They generate messenger RNA eventually that makes proteins that the immune system recognizes as foreign. We've used the analogy many times that it's like providing a new recipe to a kitchen that spits out a dish, and our immune system says that is not a dish that normally comes from us or our kitchen or our recipe book. Therefore, we are going to react violently against it and try to get rid of it and prevent it if we ever see it again. And that's what the job is of both of these things. Both of them get there. It's just that the RNA technology, messenger RNA vaccine directly, rather than being housed by a benign virus that sneaks in and actually infects our cells, but it's a special type of adenovirus typically that can't really make you sick or continue to replicate. But both of the technologies, the RNA simply is coated in a sort of inert coating that allows it to safely get into the cell. The problem is that RNA is a very delicate material. It was hard for years to make that work. So the lipid nanoparticle was very many years in the making to shepherd that RNA particle into the cell and make it a more direct process that didn't need another virus to usher it in like that. Just as an aside, there are other vaccines out there that are in the works that are protein, just pieces of protein that we inject, and that's more like the common flu vaccine. So there are other older technology viruses out there and in the works, but both of these things simply cause a protein to be made in our cells naturally. And let's not forget that a real infection does the same thing. At thousands of times larger volume, it kills often the cells that it takes over to do it. But the technology in the end product remains the same. RNA vaccines don't mess with your DNA. You'll hear people say, well, it affects our DNA. No, it does not. It affects your RNA. RNA is a short-lived, delicate molecule that does not last very long. But the immune system, thankfully, doesn't need long to be on the alert for it. It sees a few of these things and it gets very irritated, makes copies of its cells, and really amplifies its own response once it gets it. So the bottom line is it doesn't do anything that would be untoward in any sort of longer term sense. Now, the immune reaction that we get to that, even a small dose of it, can lead to the chills and the low-grade fever and the malaise that we sometimes see in vaccines. I was lucky enough not to have essentially any side effects from any of the vaccines, but some people can get fairly ill for a day or so of it. Thankfully, it recovers, and almost always people do fine. But the bottom line is that the vaccine does a similar thing to what a normal viral infection would do. It does it at a much smaller volume, and it then prepares our immune system if we ever actually see the real virus again. So thanks for that question. Any others?
Hi. So the White House released their plan about to vaccinate children, 28 million children between the ages 5 and 11. And so I guess a lot of parents are not only hesitant about getting their children vaccinated, but also just about them wearing masks. And so what would you say to parents who might be hesitant or uneasy about getting their child vaccinated?
Yeah, and the mask, just to dispense with that too. I mean, obviously, it's very controversial. It has engendered a lot of emotion on all sides. And I think the truth, as is usually the case in here, is somewhere between the extreme views on both sides. I mean, masks. People say, well, why is there mask mandate still involved since our numbers are coming down, including in kids? They peaked probably last month. I mean, I think we have to be careful in how we look at that. You can say, well, we should stop right away because it's coming down, but you have to be careful not to make that leap that some blood pressure patients make. And they say, well, I started on this blood pressure medicine and now my blood pressure is fine, so I'm going to stop the blood pressure medicine. So, it could be that those numbers are coming down as fast as they are in part because of masks. By no means let me be misinterpreted as to say that it's all because of masks. There are many factors that go into this. There's just what the virus does on its own. This virus tends to peak and seek out people to infect fairly quickly. We saw that in India. We've seen it in other countries. So even without our maneuvering, the virus may be going down on its own. But there's also no question that we do gain protection from various items that we do in the general public and in our classrooms. We've seen going back to months ago that if you take a classroom situation and you mask and you distance and so forth, it's a very well-protected environment. And there's probably an element of all of it. Now, enter the vaccine. We still have seen a lot of kids hospitalized. I mean, I've seen some here. We've had over 500 deaths nationally. Small number compared to adults, but not a small number if you have any connection to one of those kids. They're tragedies. Not to mention what we now see as increasingly problematic long COVID issues that we haven't even figured out. There's now a link to diabetes in some cases that needs to be studied a lot more, but certainly there's some concern on those fronts. So the vaccine stands to give us a fair amount of improvement. There is significant data now that say that in the 12 to 18-year-old, there's some new CDC data that it was very, very protective, saved a lot of deaths in the 12 to 18-year range and has been very safe. Now, the 5 to 11, we get into the lower age groups and we'll be using a lower dose of the actual vaccine. Even less when you talk about the ages younger than that. And the preliminary data that the FDA and the CDC are going to be looking at over the next couple of weeks, really, the FDA is going to look at it on the 26th of this month, and then the CDC has some meetings November 2nd and 3rd about this. But the data look very promising. And so we've already seen that kids are significantly protected by the adults around them getting vaccinated. But if you have a safe vaccine for kids, you're just going to get one more sphere of protection that is surrounding those kids. And so we see that the efficacy data looks very good. It seems to be the same as it is in the older kids. But obviously, there's no time to do long-term clinical studies on the kids before this particular time frame. So they looked at antibody levels and neutralizing antibody levels and found that they got a very nice boost even with the smaller dose of vaccine. So I think what to tell parents is that it's one more layer of protection for your kids. Now, again, is the mortality rate of a 5 to 11-year-old as high as it is an adult? Absolutely not. So I think we have to see what those final data are. They'll be coming out more publicly as the FDA is looking at it later this month, and we need to see what those data show. I think if we believe the output from the companies, once they're scrutinized publicly and by those committees, I suspect that they will be accurate, and they will have been accurate, and there'll be excellent safety in those vaccinations. Again, the idea that there are long-term side effects of a vaccine is not a real recognized thing anytime in the past. Yes, you can have rare reactions to vaccines, but the idea that any vaccine in history has cropped up with things a year, 2 years, 5 years later, that's never been seen before. We have not seen it after hundreds of millions of vaccines for adults, and we don't expect to see any problem in children. But I'll be the first to agree that we need to see those data. We need to see what they are, but I think it's very likely that it's going to be very protective. And when you look at kids, they are kind of the last frontier for Delta and all of the other pre-existing versions of this virus. That age group is not protected by the vaccine. And so that will be two things. It will be a population that this virus comes back again and again. It will likely circulate around the globe for some years to come, and it will just come back and squeeze a little more juice out of the orange every time it shows up. And when you have a population that is unprotected by vaccine, those kids are likely to get infected eventually, just like adults who are unvaccinated are. And I think all data right now point to it being a much safer situation to be protected by the vaccine before you encounter that virus and have a case of clinical COVID, even though kids are less in danger of that infection than are adults. I think that's still the case in kids. So I think that's the general issue. We'll see what the data, how it plays out and the specifics. But I think you'll see that that it will be, I think, protective of kids. That will be an important thing to protect that population and the population at large. I think the unprotected kids will also be a way that this virus continues to propagate through our community, causing damage to parents, grandparents in the home. We've seen this already. A kid may or may not get as sick from this. On average, they get less sick, but they certainly can then pass it to grandparents who might be much more at risk for having severe disease as well. So that's just one more avenue of protection that we could see by vaccinating our younger population. It also is the case that if you look at these models that we talked about a bit earlier today, the idea that immunity wanes significantly from natural infection, we may be encountering these infections many times over the next coming years. It may become an endemic virus. I think that's highly, highly likely at this point. And probably the best thing we can do right now is to protect our kids and our adults from the first encounter with this virus. Once you've had it, it's likely at least that the severity of that infection will be less when you have it again, maybe 2 or 3 years later, if these models bear out correctly. But again, there's a lot of individual variation with that, and that's something that's yet to be seen. We can't be certain about that. But if you extrapolate from every other disease that we know and can vaccinate against, as we look at something that's going to be with us for a very long time, it's probably, if the data bear out like we expect for the vaccine, it's going to be the safest strategy to have people protected on the front end from it. Any other questions? I would say it's just one other item that we kind of alluded to, and that is that yet again, the idea of vaccine protection, the CDC now is coming up with more data on vaccine protection. For a while there, they were not really attending very aggressively to breakthrough infections, those people who get sick. They really limited it to hospitalizations. They're now collecting and publishing more of their data on infections in both unvaccinated and in vaccinated people. And if you look at their latest data from September the 4th, it takes about a month or so to correlate these data or collate these data and make sure that you scrub any kind of inconsistencies out of it. But if you look at those data, there were less than 1 person per 100,000 in the vaccinated group died of COVID, more than 9 in the unvaccinated group. So when you really look at it, there was like more than 6-fold likelihood of getting COVID if you were unvaccinated, and an 11.3-fold increased likelihood of dying from COVID if you were unvaccinated. So just once again, we see the protection of this. Those data included about 30% of the United States via several state health departments. So just more data. You can find that on the CDC website, but it shows us just again and again the protection from the vaccine. The sad reality of it is that when you educate people about these data, it does not seem to move the needle about convincing someone to get vaccinated. There was a very interesting article about that, what things do convince people to get vaccinated and what things do not. And clearly, people who try to use scare tactics and talk about folks dying of COVID and giving them examples of people who want the vaccine after they already have it and can't get it, that doesn't work at all, seemingly, to convince people to get the vaccine. What worked the most, interestingly, was pointing out that kids are protected when we get vaccinated as adults. That seemed to actually have some impact on people. And the other was to point out the financial impact and sometimes ruin that people have faced by having months-long hospitalizations with COVID-19. Even if they recover, they're in the hospital for 3 and 4 months, and that creates huge amounts of financial distress. And both of those arguments seem to make people understand that it was probably a good idea to be vaccinated. So let me not miss the opportunity to use those items to try to convince people, because I think there are a number of arguments. But when you talk to people that haven't been vaccinated, it simply doesn't seem to be effective to point out how severe the danger is for some people, particularly the higher risk groups, not to be vaccinated. I think you have to focus on the pluses of being vaccinated, including protecting kids. And in a place like Memphis with St. Jude here, it's the kind of thing that should be in the forefront of all of our minds and concerns. Any other questions? Okay, thanks guys. Have a good weekend.